So it gives me a great pleasure to introduce Dr. David Nerenz, who's the Director Emeritus of the Center for Health Policy and Health Services Research at Henry Ford Health System Detroit. He remains active in health policy analysis and health policy research. He's also senior staff in the Department of Neurosurgery at Henry Ford Hospital. He's Associate Director of Michigan Spine Surgery Improvement Collaborative and Program Consultant to the Michigan Back Collaborative. He recently served as the chair of the Institute of Medicine Committee on Leading Health Indicators for Healthy People 2020, chair of the Institute of Medicine Subcommittee on Standardized Collection of Race Ethnicity Data for Healthcare Quality Improvement, and co-chair of the National Quality Forum's Socioeconomic Status Risk Adjustment Expert Panel, who's here to shed some light on actionable things health systems or care teams can do to reduce disparities in care. So what can we do knowing that health disparities exist? What can we do as providers and health systems to help mitigate some of those disparities? So Dr. Nerenz, take it away.
I will do that. Thank you so much for that kind introduction. And I apologize to everyone for the strange video look here. I've been in this business a long time. It's the first time I've ever done a presentation from the driver's seat of a car. We're having a little internet trouble. The car internet's the only one I can get to work. So I apologize for that. Hopefully the audio works fine. And I do hope I can tie some themes into the excellent presentation that Stephanie just shared. I want to start with a little semantic geekiness if I can. I want to distinguish between health disparities on the one hand and health care disparities on the other. They obviously are related. It's an issue of breadth. There's a lot of attention paid, and I'm glad it is, to the term health equity, which is just sort of the mirror image of health disparities. But when you use that term, I think we're really typically talking about differences that exist or do not exist at the broad population level. We might be talking about counties, states, communities, large groups of people, and usually metrics like mortality, disease incidence, prevalence, things like that. When I see the term health equity or health disparities, that's where my mind goes in an association. Now, healthcare equity and healthcare disparities to me are far narrower than that. And it's the sort of thing that we actually can get some traction on as we work in the medical care setting. And I'll get into that a little more as we go along, but I'm going to spend the time I have here talking about issues of healthcare equity and healthcare disparities, and really not so much about health equity at the community level. We work in provider organizations, hospitals primarily in the context we're talking in this evening, perhaps outpatient clinics as well. And I just want to indicate that what we do in medical care, as important as it is, and as Lisa shared with us at the beginning of this session, it's miraculous for individuals who need the magic that we can provide. And I know the wording's a little hard to see in this diagram, but these are something was put together in a program I was involved in a couple of years ago about drivers of health. What goes into health at the population level? And the healthcare part is only this little slice over on the right-hand side that's about a sixth of the total. We can quibble about what that fraction really is, and there have been estimates here or there. But the point is, what we do in medical care is crucially important for the people that we treat. Does not have massive measurable impact on these broad health indicators at the population level. So again, it's just why I want to talk about healthcare issues, not so much the broader issues of healthcare disparities. There's a massive literature on healthcare disparities. This is sort of in some ways, a launching point for a body of work, but actually at the time this came out 20 years ago, there are already 700 and some studies that could be summarized on the issue of treatment and outcome disparities. There are thousands now. I have no idea actually what the total is. It's huge. And what we find, it's relatively easy to document disparities that exist. It's a little harder to find the contributing causes. Stephanie showed a nice example of work of that type, and that's great. And it's harder yet to organize interventions to reduce or eliminate disparities and show that those interventions are effective. And that's where I'm going to spend a little time. So I'm going to mention 3-4 general strategies. And as I go through these, I think the key thing to remember is that what approach you take depends to a great extent on what you think about in terms of underlying causes and underlying dynamics. And I'll go through each one of these as I go through, but let's keep in mind that what approach you choose to take based on what you think the problem is all about. So one way to do it is to think about the typical traditional tools of process improvement. These are PDA cycles. This is Deming type work, careful data analysis, a little bit of trial and error perhaps. And what's seen here in the graph, it's actually from my own institution. It's an article I published a little while ago. What we have here are 22 primary care clinics in the Ford Medical Group. They're divided into three broad categories based on the socioeconomic status of the neighborhood they serve: low, medium, high. Um, Over on the left, what we're measuring here is hemoglobin A1C testing rates, which is a widely used primary care or health plan measure. Um, and what you can see over on the left-hand side is that the rate was lower in the lower SES clinics than in the other two classes. And this was bad. We didn't like this, not a good thing. So we went to work trying to understand underlying causes. And as you can see, as you move to the right, the disparity was made to go away. This is good. Now, there's a quirky little feature in the middle. The first thing that happened to make the disparity go away is that the high rates got lower. That's not good. That's not what you want. But then over time, everything got better. And so we ended up with everybody higher in the end than when they started and no disparity. This is good. Um, and there are a number of different things happen in the process change arena. I mentioned one here, the addition of point of care testing in the low SES sites. There are a couple other things that happened. Um, but basically, this is classic PDCA cycle type process improvement, and in this case, successful. Now, it's an interesting sidebar. The companion measure, hemoglobin A1C control, did not actually get better. There was a disparity throughout this time period, but this is an example of successful process change. Okay, what else can you do? There's the domain of care coordination, patient navigation. And in this case, you start with a different assumption. It's basically saying this is not about sort of the micro level clinical processes. We just say people with some of these social risk factors have additional needs in this area: care coordination or patient navigation. Just need more time, need more assistance, more help. Fairly basic assumption, very reasonable. I think it's true. And there are a lot of ways you can do it. And I don't go into massive detail here. I think all of this is fairly familiar to you. But basically, you make these additional services available to patients with social risk as well as clinical risk, and hopefully get good outcomes. Now, the interesting thing is when you try to look for published examples of success in this area, it's a little tough. So it's intuitively plausible to me. I think it's probably a good idea. I'm sure there are examples out there. They're just a little hard to find. Similarly, what else can you do? You can do cultural competence training or implicit bias training. These are related. They're not exactly the same. Here it's a little different starting assumption. You basically say the issue here is clinician decision making with unintended biases. So let's just go back to Stephanie, for example. Is there a reason why there are fewer referrals to cardiac rehab for Black patients? I don't know. I don't work in that area. I couldn't begin to guess. But is it possible that there's some sort of bias in the decision making that leads to that referral? Maybe. I don't know. I'm not saying yes, just it's something to think about. But if there are things like that going on, then the second basic assumption is if you make people aware of it, if you make people conscious of it, think about it, try to avoid doing it, things get better. And so, again, there are a lot of these training programs around. I happen to find an example of one from Michigan Medicine I show here. But here again, it's interesting. It's hard to find solid evidence that this works. It's plausible, reasonable, commonly done. It's hard to find examples. Two reasons I say this. I went looking in preparation for this talk. I thought I'd be able to illustrate some nice examples. It's hard to find them in the published literature. But also I serve as an abstract reviewer on some national meetings, and I get to see the kind of presentations people want to make from hospitals and other sorts of programs about programs like this. And I get abstracts all the time about we did this program, we rolled it out, we did it to many people, they all said they liked it. And then I, sort of turn over the page and say, okay, now I'm waiting to see the results. And there's nothing other than people liked it. So I think this is a reasonable thing to look at, but we need a little better data that actually makes a difference at the patient outcome level. Access to care. This is the fourth and last one I have of this general category. Here, different assumption. Now the assumption is medical care is fine, but the people in the social risk groups can't get at it. And it's a paying issue, or it's a transportation issue, or it's something else like that. So what's the obvious fix? You fix the access. You do Medicaid expansion, or you do reduction or elimination of medication copays, or you provide transportation vouchers. A lot of examples, a few examples out there with some documented success. It's another way to think about it. And finally, you can roll it together. Sorry, I promised the last one was final. This is an interesting example in the area of colorectal cancer screening. I suggest if you want to look into detail, once this is done, if you have the slides, you can take a look. It's a great story. They were worried about disparities between Black and white patients in colorectal cancer screening and actually in colorectal incidence rates and outcomes. And rather than do one thing, they did a whole bunch of things. They got all kinds of people in the community together. They got the hospital, they got the community agencies, they got social support agencies. People did all sorts of things for a period of time, looks about an 8-year period of time, and had great success. Were able to get rid of most of the disparities that they were worried about, including some of the important incidence and outcome disparities. So it's a nice story, but it says you don't do one thing, you do everything. Now, back to our setting. I think the CQI environment is wonderful for doing work on disparities or equity. The registries provide fabulous data for the treatment and outcome relationships. If we see an outcome disparity, we can look back and say, is it because we're treating differently? Or if we see treatment disparities, we can look and see if it makes an outcome difference. I think we just have a marvelous, fabulous opportunity. And it keeps going. The comparative performance data we look at all the time allow us to see in a disparity context who's doing well, who's not doing well. Is there somebody out there, if normally on average there are outcome disparities, is there somebody in the state that does not have that problem? If so, what are they doing? And we can tie into their experience, learn from that. I just think it's a fabulous opportunity that we have. And we can track over time if we start doing things. So where do I end up? Disparities are out there. We see them everywhere. You just saw, we see them in some aspects of cardiac surgery. We've seen it in spine surgery. We've seen it in other settings. And we just have fabulous, unique opportunities in the CQI context to do something tangible about it, find best practices, look to see what works, test it over time, change if it's not working, embellish it if it enhance it if it is working. So I can hope we can do a lot of this together. I think it's a great opportunity.
Thank you, Dr. Nerenz, Dr. Spehar as well. We have a question here, maybe directed to you, Dr. Nerenz, or the group in general, from one of our patient advisors, Greg Merritt, who states that he just returned from AHA Accelerating Health Equity. He wonders if what role might be possible for upstream to prevent incidence. Are people doing things like cardiac prehab, or if we have mothers, fathers, grandma, grandpa, are we pushing them to have their children enroll and be paid by insurance or even health systems to prevent? How might we involve community members? So I think this and maybe this is harkening back to some of Dr. Spehar's findings of comorbidities that are often present at the time of presentation when we're performing a heart catheterization, and obviously are associated with downstream outcomes, may be the result of various socioeconomic factors, including healthcare access over time. Are there ways, not necessarily related at the CQI context, but potentially at state or federal level policy context, to reduce disparities by focusing on prevention and incidence of disease?
Well, I'll do a quick answer and then I'll put Stephanie on the spot since I see her here and I respect her thoughts on this. In principle, yes, absolutely yes. And I was impressed with the extent these were a major mediating factor in the disparities that you saw in the data set that you have. And it just instantly begs the question, what do we do about obesity? What do we do about other comorbidities? Um, in a few cases, there can actually be some short-term prehab going into a surgical procedure, assuming that you have some lead time and it's elective. We're doing some of this now in spine, but that's a little different from a really urgent or emergent cardiac procedure. There's some of those opportunities, but I will say in general, and then I'll turn it to Stephanie. I'll say what the problem is, and she'll say what the solution is. It's hard. Behavior change is hard. working on some of these lifelong conditions is hard. It relates to now the way people live their lives. It relates to the way people have learned how to eat over long, long periods of time. It's what exercise opportunities do they have in their neighborhood? Do they live in a safe neighborhood where they can go out and do a walk or do other forms of exercise? That some of the things that we can do to change things in the OR are just far, far easier than what we can do in some of these longer term behavior or chronic disease situations. But then now Stephanie can tell us how we can do it, because somehow we have to do it. It's not, we just can't walk away and say it's hard. We just have to work on it. We have to figure out how to do it.
I wish I had the magic solution. I think that's something we're all thinking about. As a trainee, though, I think the area where I see this the most, of course, is in the primary care setting. And we have a variety of clinics across the Michigan system, but you can see the benefits of strong programming in the primary care setting as well, and having good access to some of those social support systems. So I wish I had the magic answer, but I think that's something we're all thinking about.
Great. Appears Dr. Germ has a question.
First I want to thank Dr. Nerenz and Dr. Spihar for their great presentations. And I don't have a question. I was actually hoping we can ask some of our colleagues in the community, because when I look around the state, there are some health systems that are doing a better job of engaging with the community. Henry Ford, for example, they have a population that has significant disparities. And I believe that they do a much better job of engaging the community, reaching out to the community and partnering with the community rather than trying to tell the community what they do. And, the challenge for us is in the cath lab, we provide fairly equitable care, but the patient goes back to the community. They're coming in with more comorbidities because that's the impact. And then how do we take care of it after? So after the patient leaves the cath lab. So I welcome thoughts and perspectives from some of our colleagues, especially who work in Detroit and other areas where there's far greater socioeconomic disparity than, say, in our backyard. Khaldun, I see you on the screen, maybe.
Yeah, so it's an amazing work and amazing presentations. Thank you so much. And if we think about social determinants of health, they are actually work in much more insidious and in the long term and in much more complex than what we can actually solve as a healthcare providers or healthcare systems. However, that doesn't mean we don't have a part in this. So one of the things we face in Detroit, like it is basically, if you call an ambulance in Detroit for a heart attack, it takes more than 14 minutes, sometimes 25 minutes for the ambulance to get to you. So as a Henry Ford, despite all what we've done, we are actually still not doing enough. And we need probably to collectively as healthcare providers to lobby, and we have to involve the decision makers. So one of the things we are doing now, we have a committee head by Dr. Martina Caldwell. She's actually doing a tremendous work on diversity and inclusion work. And one of the things what we're going to do this summer, there's going to be a mentoring program for the youth in Detroit. And as you know, education is a key factor in every determinant of like an income and health and everything. So we're going to start at that level and go from there. But I think that these projects need a much more than just us as healthcare providers. We need to involve the politicians, and we need to work on healthcare policy changes. And in addition to that, and interestingly, like Ann Arbor just approved the universal income. I don't know if that's going to be applied or not, but if they applied, will be interesting to know what the universal income effect on what we do in CQI. We can measure the health of the people in Ann Arbor and see if the lower income class and this in Ann Arbor will improve. So honestly, this is a great work, and we're just scratching the surface here.
Wow, that's really, really fantastic work. Sounds like that's going on at Henry Ford. We'd love to learn more about it, especially getting to the youth and education. I think really great. You touched on something about policy, and I know Dr. Nerenz has worked at a federal level on policy. And if it don't mind taking the last couple of minutes, Dr. Nerenz, to leverage some of your expertise here in trying to understand how federal policies, particularly based around value-based payment and outcomes such as HbA1c control, for example, which have disparities exist, how they're formulated such that hospitals, say like Henry Ford, that may be serving more of an underserved population or patients with different socioeconomic status than other regions, how they're not going to be disadvantaged, or other hospitals similarly won't be disadvantaged by the population that they care for.
Yeah, no, happy to do that. And I, I I think there are a couple of things I can talk about that both run under the phrase social risk adjustment, but has two distinct meanings. One of the things I've been very active in is in the discussion about statistical risk adjustment of the quality measures that are used in pay-for-performance programs. The hospital readmission program is the prototype one. It's probably the best known. Hospitals all over the country are penalized for excess readmissions. And we've known for 10 years now that safety net hospitals are much more likely to be penalized than others. And the question is, do they actually provide poorer quality care so that you might say these penalties are justified, at least mathematically and statistically? Or are the readmissions reflected of factors outside the hospital control that live somewhere in the community in the 30 days after discharge? At which point the penalties are massively unfair because they don't really reflect quality of what the hospital is doing, and they have the effect of taking financial resources away from the hospitals that need them the most. You can tell which side of this argument I'm typically on. Um, but this goes on, and actually CMS has done a little bit recently because Congress forced them to do it in stratifying hospitals in the readmission penalty program in quintiles by the percent of dual eligible patients, and then assigning the penalties on where you stand relative to your quintile as opposed to overall. And it's had the effect of evening out the penalties a little bit. It's basically a good thing. I'm not sure it's the whole answer. And you can play this out. And one of the things I wrote a couple articles about because I'm worried about it is how this plays out in the MIPS program for physicians or in any other thing where now it's individual clinicians or medical groups. Because what we have seen happen already is that the medical groups who serve socially vulnerable patients do worse in these programs. They either get smaller rewards or they get heavier punishments, depending on exactly where they fall. And you have to first decide, is that sort of fair because they're actually a poor quality provider? I think not, based on the evidence I have. But then it's bad because not only do you have the same problem of pulling resources away from where it's needed, but because clinicians are far more mobile than hospitals. They're just discouraged from serving inner city areas or poor rural areas. Now you have access problems. So all these policies that are designed to incentivize better care can have the really perverse effect of making things worse. And I have been very active on that. Now, the other thing about social risk adjustment is you can work to the payment side and then offer some additional front end money, say to safety net providers, to provide transportation services, to do extra care coordination, to do more. There are good examples of that. Massachusetts is a good example of that. It's another good approach. And to me, at least so far, it's kind of an either or. If you provide the additional resources, there's less need to adjust the quality metrics. If you don't provide additional resources, it probably does make sense to adjust the quality metrics. So I'm in the middle of this on a daily basis. It's not the whole story by far, but it's a part of it. It's just, where do we want money to go if we want to promote equity? A colleague of mine on one of these national committees said, what we're doing now is taking millions of dollars every year and sending it from Detroit to Scottsdale. Is that what we want to do? So you can decide if that's what we want to do.
I think that last comment sums it up quite well. Certainly appreciate your expertise, and I hope you get some power back so you don't have to stay in the car to do it.
I'll try.
And just a note to everyone, just like Dr. Aliswad was pointing out, some of the great work Henry Ford's doing in attempting to mitigate some of these disparities. There are other examples of it at other sites. I think that's one of the benefits of CQIs, is just sharing what each hospital may be doing uniquely such that we can learn from each other. So feel free to send it to myself or Dr. Gurm or our coordinating center.